Assalamu alaikum wa rahmatullahi wa barakatuh. In summary, patient who present to you with type 2 diabetes. Metformin is the preferred initial pharmacological agent. We start with metformin unless it is contraindicated or not tolerated. And when you start metformin, keep on metformin and add other medicine to it, as long as it is tolerated and not contraindicated. You can add other oral hypoglycemic agent, and you can add insulin in addition to metformin. Early combination therapy, that is metformin with other oral hypoglycemic agent, should be considered early in therapy, as studies have showed that early combination therapy or early control of hemoglobin A1C will result in long-term better remission rate and delay the pancreatic failure and the need of insulin. Consider early introduction of insulin. Insulin eventually will be required in most patients with type 2 diabetes as pancreatic failure progress, reaching to the degree of failure of pancreatic cell to secrete insulin. But early introduction of insulin should be considered in three conditions. First, if there is evidence of ongoing catabolism, if the patient has weight loss or ketosis, this patient we should start insulin early. Or if there is symptom of hyperglycemia like polyuria, polydipsia, dry mouth, if he is symptomatic, we can start insulin at this point. But remember also, if the patient is symptomatic, sulfonylurea is an option in such patients. We can delay the introduction of insulin and use sulfonylurea in patient who is symptomatic. We will get a rapid control of hypoglycemia. And the third patient with glucose toxicity, who has hemoglobin A1C more than 10 or blood glucose level consistently more than 300 milligram per deciliter. This patient usually has glucotoxicity, so he needs insulin in order to reverse glucotoxicity to pancreatic beta cell and allow oral hypoglycemic medication to be started. Otherwise, insulin should be started when other medication fail to achieve adequate control of hemoglobin A1C. How we will start insulin in patients with type 2 diabetes? It is very simple. We start with basal insulin. Basal insulin, we have major three types: diglodic, galergine, and the protamine insulin. The best one is the diglodic, less hypoglycemia, followed by galergine, that is 300 unit per 1 ml. This is better than glargine, that is 100 unit per 1 ml. This will lead to less 300 milligram formula will lead to less hypoglycemia and more durable effect than the 100 unit per ml. Followed by the protamine insulin. How we start? We start at evening dose, simply with 10 units of insulin in the evening. We give 10 units insulin in the evening for the patient with type 2. Usually we stop other oral hypoglycemic except metformin, and metformin should be kept. And we can also keep gliptin if he is taking gliptin, as this will lead to more physiological control of postprandial surge of sugar. This both medication, gliptins like sitagliptins and metformin, both can be kept. Metformin should be kept, but sitagliptin and related DPP4 inhibitors can be kept or used added to the insulin. How we will titrate insulin? We will titrate insulin every 3 days by checking fasting blood sugar. If it is outside the range, we will titrate by increasing the dose of insulin by 2 units till we reach to what we called over-basalization. What do we mean by over-basalization? Over-basalization, when the dose of basal insulin become 0.5 unit per kg For example, if the patient is weight is 100 milligram, 100 kg, if we give him 50 unit insulin like glargine or protamine, and we are not reaching the goal, this means we are reaching the overbasalization. Also, if there is marked difference between fasting glucose and bedtime glucose, if the or pre-prandial and post-prandial glucose, if the difference is more than 50 milligram between these readings, this means we had reached the overbasalization. In such case, we should add Prandial insulin. Prandial insulin, we have the regular human insulin, and we have the synthetic aspart and Lispro insulin. This is the rapid-acting insulins that can be used with the main meal. We start simply with 4 units with the lunch, which is the main meal for most of the patients, and then titrate twice weekly by increasing 2 unit titration till we reach to the target level of controlling hemoglobin A1C and fasting glucose, and prevent variation in glucose level. And as we said, we should keep using the metformin. Metformin, it should be, the dose is 2 grams if tolerated. This is the usual and the adequate dose of metformin. We should keep using this because it is associated with better cardiovascular outcome. And we can use the DPP4 inhibitors like sitagliptin for more physiological control of postprandial surge of sugar. Other oral hypoglycemic agents, we can use the sodium glucose cotransporter 2 inhibitor like for Xiga. This can be used, but with caution, especially the patient may develop normal euglycemic ketoacidosis. So this can be used, but with caution and only on special indication.